Welcome to the new podcast, Leading Minds, expert voices from the College of Medicine, Nursing and Health Sciences at NUI Galway. My name is Jonathan McCrea. The aim of the college is to improve patient outcome and explore healthcare, and really excited to speak with the panel today about cardiology, where it's come from and where it's going to in the future. We have a fantastic panel joining us. They are Professor William Wijns, Professor Patrick Serruys, and Professor David Wood, all of whom are global change makers in their own specialisms. And they cover the whole research spectrum from intervention to prevention to rehabilitation. So really looking forward to hearing this discussion, all of them professors here at NUI Galway. So William, perhaps we might start with you, if that's okay. And this figure always bamboozles me, the idea that over a third of all deaths in the EU are as a result of heart disease. And many of these are as a result of events like cardiac arrests and heart attacks. I'm wondering if you might tell us a little bit about your research and what causes these sort of events.
Yes, sure. I actually looked up the numbers for Ireland, and they're pretty impressive. For male, we have 700 deaths from cardiovascular disease per 100,000, which means number 13 among all countries in the world. And for ladies, the figure is a bit lower, but still very significant, 420 for 100,000. So we're talking about an ubiquitous disease that is characterized by the accumulation of what we call plaque, which is basically thickening of the vessel walls. And when there is a disruption of that plaque, that leads to an acute event. That can be acute chest pain with an infarction or impending infarction. It can be an acute coronary syndrome, all of which need emergency hospitalization. And so trying to prevent these acute events is, I think, one of the major unmet needs in cardiovascular disease today. So this has been the focus of my research since I joined NUI Galway in 2016, actually, September 2016.
So tell me a little bit more about your research, William. What exactly do you specialize in? And tell me a little bit about the medical devices, how they might help us prevent and monitor things like heart disease.
Yeah, you use exactly the two right words, monitor and prevent. I'm actually focusing on the high risk patients. Now, who's a high risk? A person who had an event already, plus a very large number of healthy carriers of what we call dangerous plaque that can disrupt when the wrong trigger appears. And the triggers, the most important ones that I'm focusing on are high blood pressure, high pressure in the arterial circulation, but also in the coronary circulation. And the second trigger is stress, because emotional stress can trigger an acute event in patients or subjects who happen to carry those plaques. And so by monitoring very carefully changes in blood pressure, we hope to be able to identify patients who are at high risk of fracturing, disrupting one of those plaques, which then leads to occlusion of that particular vessel. And if nothing is done about it, the heart that depends in terms of blood supply and oxygen from that vessel, that piece of the heart might actually die. So we're using sensors for that purpose. We all know how blood pressure is being measured once in a while using the cuff. We're trying to develop sensors, wearable or very small implantable sensors that could measure this continuously in an unobtrusive way, send it to the cloud, and this be recorded for monitoring over time. The other trigger that we're trying to measure is stress. And we're talking about accumulating data, lots of data in the same patient. So big data in a way, which is, everybody talks about. We're accumulating big data in one person so that we can identify the moment when there is a risk for one of those plaques to rupture. The other aspect is to monitor biochemicals. I mean, these are substances that can be measured by a blood test, and some of them are indicative of either suffering of the myocardium. These are the enzymes like or proteins like troponin, and if we want to measure those continuously on a daily basis, typically this would be measured when the patient comes in acutely with some symptoms. But nothing is done when people live their normal life on an ambulatory basis. So, using these biochemicals, just like patients with diabetes measure their glucose, we hope to be able to monitor signs of either heart suffering, damage, and other markers that, for instance, are telling us about heart failure. They're called NT-proBNPs. These are also proteins that are secreted by the right atrium. And when the level increases in blood, it's a sign of an exacerbation of heart failure. So we're focusing on high risk patients, and by measuring a number of key biomarkers or triggers of acute events, we hope to be able to prevent them. That's the focus of my work.
It's interesting what you talk about because, of course, this wouldn't have been possible without the miniaturization of sensors, the miniaturization of technology, the idea of constantly monitoring a patient 10 or 15 years ago for blood pressure and stress and even biomarkers in the blood. It was absolute sci-fi. But I don't know if you remember the cartoon, The Jetsons. In this, there was an episode in which the dad who lives in the future got a call from his doctor to say, you better get to the hospital. And George Jetson said, why? And the doctor says, you're about to have a heart attack. And that seemed so crazy at the time, but it seems like we're getting closer to this idea of being able to sense what's happening in the blood in the body, and do something about it before that event happens. Is that something that is theoretically possible now, or is that what you're working towards?
Yeah, that's what we're trying to achieve. I mean, the two keywords, one is personalized care. So this would be, in the first place, an option for super high risk patients. Yeah. And the second is miniaturization, as you said. But that's the story of our life, because as an interventional cardiologist, what we've been trying to do is to reach the site of treatment via a friendly endovascular route using actually minimal access. So that was requesting miniaturization of the stents and devices that are used. So same is true for the sensors.
Yeah, I want to talk a little bit more about that technology, but uh, Patrick, let's go to you because talking about acute events, when someone arrives in the lab, knowing what's going on in the body is extremely important. And you're doing some amazing work in imaging. I'd love if you maybe use that as an introduction to some of the other projects that you're also working on. But talk to me about how we used to image these patients and how we're hoping to change that.
It's true that everything starts by recent onset of angina. Okay, you have chest pain, and then you see a doctor in the hospital or not in the hospital, and the first thing you do, you make an interview of that individual, when the pain start, how much, etc. The second aspect is that you look at the risk of this individual, but then came the critical moment, you make an electrocardiogram. And if you see on this electrocardiogram an ST elevation, you rush to the cath lab. And that's the field of primary intervention for acute myocardial infarction. Now, let's say that you don't see anything on the electrocardiogram, and the troponin is positive or negative, but what you start to do, you enter the field of non-invasive testing. And it might be exercise testing, it might be dobutamine stress, it might be MRI with hyperemia, it might be PET spectalium, name it. And all these tests have a certain positivity, sensitivity, specificity. And then, as a physician, you discuss that with the patient. You start to treat him, giving aspirin, beta blocker, things for the symptoms, but you are uncertain. Okay, you are uncertain, and then for prognostic reason, because of uncertainties, at some point you move to the cath lab. And in the cath lab, you have to make the stick in the groin or the stick in the wrist, and you shoot the angiography multiple times. And then you do an ad hoc intervention, which is not very well prepared and which is basically based on your visual assessment of the lesion. So that's something we want to replace. That's the vision, the pathway of the past, and we have a certain vision of the future where the non-invasive imaging will be used as a one-stop shop. Okay, you go a multislice CT scan, and you get the anatomy, you get the wall motion, you get the ejection fraction, you get the calcification, you get all kind of score, and you can at that stage already discuss with the surgeon or with your colleague, is that a surgical case, is the disease very clear, because you have also a functional component which is called FFRCT, fractional flow reserve, okay, ratio. So with that information, you can now plan, not only make a decision making between pharma treatment, surgery, or PCI, but you can plan your procedure. Okay. And you know that the next day, not in a cath lab, but in an interventional suite, you know exactly in which projection you have to work. You know what you have to prepare. If there is a lot of calcium, maybe we need some rotational atherectomy and so the quality of the medicine is everything in the planning. You may ask a colleague which is a more expert in total occlusion. That's the future, the multislice CT scan. Now, what is interesting is NICE, which is cost effective, excellent medicine in UK, has in 2017 promote the concept that the multislice CT scan with functional assessment by FFR-CT should be the first line of diagnostic. And they said, they calculate that theoretically you can spare 240 pounds per patient by avoiding a treatment or suppressing some other test. Because I forgot to tell you that only 30% of the ad hoc intervention, in 60% of the case, either the coronary artery were pristine and you did that for nothing, or even worse, you have what we call NOCA, non-obstructive coronary artery disease. It's too early for PCI, it's too early for bypass surgery. You need prevention because they are dangerous patients. There has all this bump in the coronary artery that William was alluding to, which are these vulnerable plaque, not flow limiting, but who could rupture. So that's the general plan.
So this multi-slice CT scanning, it basically cuts down on cost, cuts down on exploratory interventions, and gives you an overview of everything that's going on in the heart. Is there a new technology that you require to build this sort of imaging, or is it a matter of compositing images that you can already take? Why are we not already doing this?
No, I mean it's available, and of course it's the improvement is every year, as every day there are improvement in that technology, but it's something that you can implement. And if you look in UK between 2017 and 2021, they just make a report. I mentioned the fact that they were calculating that you could reduce save 217 pounds per patient. Now, the report in January showed that it's not 217, it is 354. So that's going to go in the right direction because healthcare You cannot escalate the cost all the time. We have to be responsible. So I think it's a good step in that direction. Of course, the technology will improve all the time. The trial that we are doing is unique in the world. It is what we call a first in man. The name of the trial was found by William. He called that fast track cabbage, fast track surgery. And the concept is that you don't do any more cine angiography. You do a multislice CT scan. You analyze everything, and that's what we do in the Corib lab here in Galway. And then we dispatch the result to the surgeon in Europe, in Italy, in Germany, in Belgium, and you say, yes, this is a patient for surgery, and you have to put a bypass here and there and there. And when you think about that, they have the most complicated case, the case with left main, the case with three vessel disease. And if the surgeon, and they do, accept the guidance of the multislice CT scan to operate this patient, the most complicated, we interventional cardiologists can do the one vessel, the two vessel flow limiting lesion. We have to do that before the cath lab. We don't call that cath lab, we call that interventional suite. Because today, you have the CTO, the bifurcation, the aortic valve, the mitral valve, all these kind of activities which need fluoroscopy and needs a lot of time. So it is very essential in terms of cost effectiveness for two reasons to do that via the multislice CT scan non-invasive. And at the bottom of the pyramid of the activity for the multislice CT scan, the top is for the surgeon, the bottom, you do a multislice CT scan and your coronary artery are pristine, fine, rule out, you can go on. Then there is this layer of NOCA. That's the patient we have to treat. And we are planning in this patient the use of messenger RNA to block the PCSK9. And the PCSK9 is something very important for the LDL receptors, the fact that the liver clean the LDL cholesterol in blood. So that's the NOCA, that's the target for primary prevention. And then in between the surgeon and the NOCA, you have the interventional cardiologist with one and two vessel disease. That's the vision, the pyramid.
It's very promising stuff, and it sounds almost like a very complicated triage in a way. But obviously, ideally, we wouldn't have any patients in our hospitals presenting for heart disease because we had interacted and intervened before that. And I'm talking, of course, of preventative medicine, which is something you've dedicated your life to, David. Can you tell me a little bit about why you got into preventative medicine and what sort of interventions are there to improve outcome when we talk about these incredible figures of deaths as a result of heart disease?
Well, I think to begin with, we should understand that, as Salim Yusuf described in his Interheart study across 52 countries, the explanation for coronary artery disease, the causes of coronary artery disease, are summarized by 9 risk factors. They explain 90% of the population attributable risk. And those include aspects of lifestyle, the biological risk factors such as hypertension and dyslipidemia and diabetes, together with psychosocial factors. And this means that the cause of coronary artery disease is the same worldwide, and it is preventable. But the challenge for the preventive cardiologist is at 3 levels. The first is for those patients that Patrick and William are describing who have survived that initial ischemic insult and who've been revascularized, but still have the disease. The disease is ubiquitous, it is present throughout the arterial tree, and therefore we need to address
those drivers of atherosclerosis in order to prevent recurrence. And in our research at the National Institute for Prevention and Cardiovascular Health, we are conducting an international study called InterAspire across 18 countries drawn from all 6 WHO regions to really drill down into the risk factor profile of patients who've survived that initial ischemic insult and to look beyond the conventional risk factors that I described earlier and to look at new risk markers, novel biomarkers, in order to better understand and characterize their risk, and then develop models of care which can reduce that risk and therefore the chances of a further heart attack or stroke.
How precise can you be? Because obviously you're talking about thousands and thousands of patients. You can get an idea of these sort of risk factors, but when it comes to the individual, how important is that that preventative intervention when it comes to someone who may have different genes than was in the profile, a different environment, because our own lives are so individual?
Well, risk scoring is absolutely central to the work that all of us are doing, because to be able to predict better recurrent events in those who have established disease, and much more importantly, the much bigger problem of predicting in the general population amongst asymptomatic individuals, those who are at high risk of developing a first major cardiovascular event, is a real challenge. And the WHO risk prediction charts, of which I was part and published in the Lancet in 2019, now make available risk prediction models for every region of the world. But as with all risk prediction, you have to understand that this is based on groups, not the individual. So all we can say to the patient in front of us or to the asymptomatic individual is that the probability of you developing cardiovascular disease over a defined period of time, let's say 10 years, is 20%. That could be tonight, or it could be in 10 years' time. And it's not necessarily you, it could be somebody else in that group who has the same level of cardiovascular risk. So improving risk prediction is a real challenge in both secondary and primary prevention.
When you talk about new risk factors, you talked about psychosocial factors and lifestyle factors. Genetic, I'm sure, is another element as to why people are more likely to get one of these heart diseases. Have we yet identified a new risk factor, and will AI be very important in doing that, or how do you hope to identify these new risk factors?
Well, that's a very interesting question, because if you look at the mathematics of risk prediction, you will see that actually the conventional risk factors explain the greater part of the ROC curve. And the addition of novel biomarkers, or indeed imaging modalities, adds an independent contribution to that risk prediction, but it is relatively small. So, of course, we can improve risk prediction by using novel biomarkers. We can improve risk prediction by imaging, but as we add more and more layers of risk assessment with more and more sophisticated technologies, the more challenging this becomes in population screening. Good for the individual, but not good for populations as a whole. And that's why the WHO risk prediction charts rely heavily on the conventional risk factors, but at an individual level for the physician, for the cardiologist or the general practitioner, they could, of course, order these additional tests and better characterize the individual's risk.
Is there big variability in an approach to prevention? And are there things that are quite exciting that are happening elsewhere that we could be doing?
Well, there is huge variability in approaches to prevention, and even in high-income countries, we still fall well below the standards, as we have demonstrated many times over in our EuroAspire studies. We fall well below the standards set in the guidelines in terms of patient management. And the challenge is even greater in middle and in low income countries, which actually is where most of the deaths from cardiovascular disease currently occur. And we are seeing an epidemiological transition with falling mortality rates in high income countries, but growing mortality rates in middle and low income countries. And that is a significant challenge for the future.
Speaking about innovation, Apple is one of those companies really that we identify as always looking to try new approaches with technology and break boundaries. Um, Patrick, can you tell us a little bit about your approach to innovation when it comes to medicine? Your fast track trial, which you talked about, is just one of, I believe, 13 different approaches to innovation that you're working on in your lab. Maybe you might talk to me about how that works and some of the projects that you're working on.
Yeah, I describe what I call the pyramid of coronary artery disease. So we have already discussed the fast track. I mean, basically the trial is has include 25% of the patient, and don't forget that the surgeon has always the option to say no. The multislice CT scan information is not good enough. I want to see the real things, the cine angiography, the invasive angiography. That's the feasibility phase. Okay. And then to be sure that we don't do something wrong, we have a safety phase. So 30 days after the surgery, the patient get a second multislice CT scan to control all the bypass. Did they put the bypass in the right place uh, behind the stenotic lesion and so far it goes very well because the feasibility has been 100%. What we were not expecting, we were expecting 75%, and the control, the safety looks also very good. But we have to complete that trial to see if it is applicable to more than a few top surgical centers. That's the top of the pyramid. Now, the second interest that we have, is of course, we mentioned that the NOCA, the non-obstructive coronary disease, that's really a killer. It's a big paradox. I mean, with the central unit in Monzino and Professor Daniele Andreini, we have followed for 7 years these patients who have not even encroachment of the lumen. The plaque is there. 40% of plaque is there. You know, after 40%, you got the encroachment, the lumen. We have take this patient and follow them. Now, at 8 years, only 76% were even free. So that's really a target. The same number that the patient who has a stenotic lesion flow limiting. So that's really was for me a major target because I cannot, the surgeon cannot treat it. The interventional cardiologist cannot treat it. So that's basically the field of David Wood. Now, what is fantastic, I mean, the people don't realize that the COVID has introduced something amazing. I think we will remember the COVID not for the catastrophe, but for the good things. Do you realize that almost million of people, even billion of people, receive now a piece of messenger RNA subcutaneous and then are protected against the virus. So you must realize you have a small microsphere of lipid with a piece of messenger RNA. You put that subcutaneously, and it goes up to the liver, get integrated in the liver. In the case of PCSK9, sorry, I make it short. The block the PCSK9 so that the liver has better receptor in its surface in this cell, and can clean the LDL cholesterol from your blood. So I think the decade we will see a lot of messenger RNA therapy, microRNA. You know, the decade before, all the drug was called MAB, monoclonal antibody. Now, many of the drug will be microRNA, and the COVID has promoted that. But before the COVID, there was already one drug in the possession of Novartis, inclisiran, and these people are now targeting primary prevention. And with Oxford and Sir Rory Collins, they want to include 40,000 patients and include kids between 12 and 18, which has the bad genomic, who have familial cholesterolemia, and include in this trial. I think it's phenomenal. I think it's so exciting. And, you know, two subcutaneous injection made by the GP, you will have an adherence, phenomenal adherence. You know, if you have to take your statin every day, you can't forget it. Okay? But to have two subcutaneous injections per year by the GP, that is going to have an impact. What I like very much in prevention, you know, an interventional cardiologist aging goes in prevention. That's very clear. So, so what I like also very much, and David didn't allude to, is with my friend Valentin Förster, what he has done for the kids between 3 and 6 years. You know, he start the prevention at that time. If you take a kid of 3 to 6 years and tell you that smoking is bad, drug is bad, too much lipid, too much meat is bad, it creates something. So Valentin Försters has a randomized school where there was an extra education for the kids and a normal education. And you cannot judge the result because primary prevention, you have to wait. But the very interesting things is that you use Sesame Street to disseminate that concept. And he tried that in Bolivia, he tried that in the Bronx and the Queens, and he tried that in Madrid. And now he told me the other day that he takes this kid that he has educated between 3 and 5 years, and now 5 years later, he takes the same kids. And he said to talk again about prevention is extremely effective in these kids. They have had the concept at a very young age, and now you are coming back at the age of 10, and that trigger again the same reflex. So I'm a believer that I would not say that surgery and PCI will disappear, no, but we go in that direction, clearly. We go in that direction. Molecular biology, genomic, identify, non-invasive imaging for the phenotype of the disease, and prevention. Yeah.
That sounds really exciting. But there's sort of two ideas there to kind of toss around, David. When we talk about prevention, I mean, those sort of really early interventions, obviously, hopefully will have some sort of impact. You might talk about what that looks like and whether or not you feel they're hopeful, but also the idea that essentially we might make people immune by using these new mRNA treatments that are becoming more popular, not just in cardiology, but in lots of other specialties as well. So can you talk a little bit about both of those really early preventions, and then possibly the future of getting 2 jabs and you're done?
Well, Valentin Fuster's work is absolutely inspirational with children, and that is the future. Primordial prevention at the level of children and young people. But Can I just comment on COVID-19, this catastrophe, global catastrophe, both in medical terms and social and economic terms? Because if you want a compelling argument for prevention, as Michael Bloomberg said recently, and he's the WHO Global Ambassador for Non-Communicable Diseases, the people who are admitted to hospital, the people who are being ventilated in ITU, the people who are dying from COVID-19 are the people with comorbidities, with heart attacks, with strokes, with hypertension, with obesity, with diabetes. And you could not have a more compelling argument for prevention than that. But COVID-19 has, I think, brought about some dramatic changes in our thinking about how we deliver care, so that virtual consultations have become at least the norm in my country, replacing the traditional outpatient clinic consultation, with the cardiologist armed with all of the investigations, the patient medical record, and a telephone or WhatsApp. I think this new way of delivering care, and that is what we are currently developing at the Institute, the Intercept model for preventive cardiology, using a customized application which is made available to the patient and family on their iPhone or Android, is a very different way of thinking about how we can reduce cardiovascular risk. So the pandemic has had terrible consequences for every country, but actually has brought about innovation at the same time, and innovation which I think is here to stay for cardiology.
Yeah. I think a lot of things had to happen very quickly when it came to COVID, and some of them were unfortunate and maybe makeshift, and then others sort of forced some institutions into the 21st century. So there's definitely, and also approaches how we think about health, how we value science. All of these things changed quite dramatically during COVID. It was, I did want to hear from you though, with regards to what Patrick was talking about in terms of intervening with mRNA. Is that something that's on the horizon for you? Do you think that is possible in terms of intervening with sort of preventative injections to reduce risk of heart disease later?
Oh, without a doubt. I mean, the Novartis drug inclisiran, and we wait to see the results of the phase 3 trials, is an extremely promising approach to prevention for the reasons that Patrick gave. Compliance or adherence with cardioprotective medications is poor among many patients, and approximately half of all patients prescribed a statin, even though they have coronary artery disease, stop taking their medication. The best example I ever read was Bill Clinton. And he was prescribed a statin to reduce his cardiovascular risk. His cholesterol level fell, and he thought the job was done, and he stopped taking his statin. So compliance with medications is a real problem, and an alternative, namely an injection every 6 months, will ensure absolute compliance if the patient comes forward for the injection, and will therefore give sustained reduction in cardiovascular risk. This is a new vehicle for prevention.
Yeah, and I know that statistic, and it just it's mad, isn't it? The idea that you've had a heart attack, this will stop you having another heart attack. All you need to do is take one or two of these pills a day, and that won't happen to you again. And people still dramatically, a large number of people just do not sign up to that prescription for some reason. I'd like to hear finally from each of you about the importance of being at NUI Galway, how and why you were lured here, and why it's good to be here for your research. perhaps a little bit about your work and collaboration with other departments and other professors within cardiology and medicine, and also the fact that Ireland is a fantastic place for medical technology research. So maybe we might start with you, Patrick. Why is NUI Galway a good place for this?
Yeah, I mean, obviously, it's the nickname of Galway is the Silicon Valley of Europe because you have a huge brain park. All the med tech is around in the brain park, so that's one point which is very attractive. Now, to come back to the COVID, I want to tell you an anecdote because it will show you the not only the attraction of Galway, but how Galway can interact with the COVID and with the international community. And the anecdote is the following: we had the two Chinese fellow, Charlie Gao and Wu Tao Wang. And when the things get serious in China, January, the end of January was clear that the pandemic was coming. They decided to leave Galway because they were here in Galway as fellows. They had followed us from Rotterdam and to go back to their country. And they volunteered to work in these Wuhan hospital. You remember that? That hospital was built in 3 weeks. And they start to work on February the 2nd, and they saw only COVID patient all the time. So they called me and I said on April the 1st, and they say, could you help us to write a manuscript about the COVID? We believe that hypertension is very bad, and said, okay, you have the data? Yes, we have collect the data from February the 2nd to April the 1st. So I get in contact with William, I get in contact with Bill McAvoy. We got the data, we helped to write the manuscript, and there was two important pieces of information. Yes, hypertension was very bad for somebody who get COVID. But the second information was even more important. People who were taking angiotensin 2 inhibitors, because there are some similitude between the receptors for the COVID virus and for the angiotensin 2 inhibitors, people said you have maybe to stop the inhibitor of angiotensin 2. And we look in this data, and it was not the case. It was maybe even somewhat protecting. So we put a manuscript very quickly for the European Heart Journal, and everybody has help. It was immediately accepted as a fast track with the contribution of Galway and the contribution of our Chinese fellow. It was published very quickly in the European Heart Journal because it was hot news, very important for the community, and it was confirmed many, many times around the world. And that paper was a big success for Galway. It was in the, I don't know, Irish News, whatever, the journal. And the Altmetrics, which is calculating how much a scientific paper is important for the community, Twitter, and also, I think after 3 days was 1,400 uh, score, which we have never seen before. So that show you the international connection with Galway, the prevention, because Professor McAvoy is working in prevention. We even at that time make a protocol for a grant about testing different antidiuretic drugs. Unfortunately, the grant was not approved, with the idea that Galway is a too small place, and by the way, the disease will disappear. Now, they forgot that there was a second wave and a third wave, so we could have done the protocol and tested that in Galway. So that's my impact of connection with the COVID. But what is important is that you must realize that in the lab behind me, there are five Chinese, five Japanese, people from Italy, uh, 5 people from Egypt. That show now today the attraction of this place. You were asking what is attracting Galway. It's of course some personality like David Wood and William Wijns and many others, but certainly it is on the international map. Galway is there.
Well, my association with Galway goes back more than a decade with CRE, the Heart and Stroke charity. And I then had the privilege of being awarded an adjunct professorship in preventive cardiology by NUIG. But what was really exciting was the creation of this National Institute for Prevention and Cardiovascular Health, led by Professor Bill McAvoy. Tim O'Brien recruited him from Johns Hopkins, and he is an excellent leader. And so I was very pleased to have the opportunity to join and support him in his bid to build a research and educational agenda in preventive cardiology. Indeed, my whole team from Imperial College is now in Galway. So together we span the spectrum from prevention to intervention, and in a very beautiful part of the world.
William, you get the final word. What is it? What is important?
Oh, may I have the final word? Just because I have to say something to William, so I cannot say after William. Okay, so I was in Singapore. I was in Singapore, and I got an email of William Wijns on the 6th of July 2019. And he said, Patrick, would you be interested to come in Galway to build up a core lab? Because they have a lot of data, but they are not analyzing, and they are not analyzing data not only from Galway but internationally. And it's a fatal attraction. It's a fatal attraction because you must realize that he's a little bit younger than me. Doesn't look like that, but he's a little bit younger than me by 4 or 5 years. And I was already a resident, very established in Rotterdam when he joined us to learn the early phase of PCI. So we worked together between, I think, 1980 and 1983. I was a little bit his boss. He was a little bit in training. After that, he went to Los Angeles. So when I talk about fatal attraction, you understand, after 40 years to come back to the same partner to build them something in Galway was unique. Now you may have the last word.
William, you have to say something nice about Patrick now, I believe.
Yeah, for sure. There is one movie that I didn't see that I have to try and watch maybe on Netflix. Fatal Attraction. I haven't seen it, but just seriously, um, uh, for a person at my level of career and interest in intervention and having a broader impact, having the opportunity to join what is called the Galway and Irish ecosystem in is just a unique opportunity. And of course, I'm immensely thankful to Science Foundation Ireland for giving me this opportunity to reunite with my former mentor, but and beyond that, joining all the colleagues that are interested in innovation and research, Curram, BioInnovate, Insight, Translational Device Lab. I mean, so many opportunities for collaboration, innovation that you can dream of. So I couldn't think of a better cherry on the cake of my career, to use a funny word. But if you know my background, I come from a bakery and a pastry family, so cakes are very important for us. Probably I should do this again because it's absolute nonsense. Yeah, what I said. Maybe I should record this again. But Patrick destabilized me with his personal, touching comments.
No, you expressed it very well, William.
Well,
Well, thank you so much to our panel, Professor Serruys, Professor Wijns, and Professor Wood. And thank you for watching. If you'd like to know more about the research that's been discussed here, you can go to nuigalway.ie/CMNHS. Thank you for watching. I hope to see you on the next episode. Good afternoon, good morning, good evening, wherever you are. We'll see you again soon.